The purpose of the webinar today is to kind of go, well, not kind of, to actually go over questions that have been asked on SuperCoder over the past year, and questions that have become very popular. And the idea was that instead of the quick, short answers that you get on the webinar, excuse me, on the SuperCoder Ask the Expert site, it could do maybe a little bit more detail and allow you to see what's going on as far as what goes into answering some of these questions. So we've got 10 questions, and I'm going to start, of course, in order. Not necessarily in order of the most popular, but basically as I was looking at them, I thought, well, this made some sense to answer this one first. The first question that was asked, and it's asked frequently, is how do you code and bill for a depot injection? Well, as most of you should know by now, Depo stands for Depoprovera, and that is the trade name for the generic, which is medroxyprogesterone acetate. This particular drug has been cleared by the FDA to give for contraceptive management, and normally it's administered at a dosage of 150 milligrams every 3 months. But caution here is it can cause severe bone density loss, and so most patients do not use it for a very long period of time because, quite frankly, some of the data is showing that the longer they're on it, the less reversible that bone loss might be. There's also now a lower dosage, 104 milligrams, same drug. It's also used for contraception, but also the FDA has approved that lower dose for the management of pain associated with endometriosis. So diagnostic coding needs to be important here if you're knowing the reason for it and the dosage. If you know it's 104 milligrams, be sure you check that it's for contraceptive or for endometrial pain or due to the endometriosis. We have CPT codes, of course, that need to be billed with this. 96372 is your injection code, and you use that whether it's the sub-Q lower dose or the IM injection. Your documentation in the record should include what the drug was injected, how much was it, what were the vital signs of the patient prior to giving this, and what's the patient's response to the injection. The reason I'm telling you this is because the next step is that the code 99211, which is what we call the nurse visit, is never billed in conjunction with 96372. 99211 can only be billed if there is no supervising provider in the office when the injection is given, in which case you bill 99211 and not 96372. But remember that if this is a Medicare patient, you will not be able to, and there are a few out there that have contraception that require this, or that it would be the lower dose due to the pain. Medicare would not allow you to bill if the visit is not supervised or at the time of the injection. If the provider performs a significant unrelated E&M, in other words, the note is not involved about giving the injection, but it involves some other thing that the patient is complaining of that day or something else that needs to be evaluated, you can bill that other level of E&M service starting with a 99212 if she's established, or 99201 if she is new patient. And remembering to add a 25 modifier, but the note must clearly show it was significant and separate from that injection.